Guys,
Okay.
let's continue our conversation with Dr. Hassan Shahid about the AMC2. So, Hassan, please take it away.
Yeah, thank you so much. So in the last presentation, we talked about AMC MCQ exam, and just a brief highlighting about the pathway, the different types of registrations that we talked about AMC1, and now we'll just be focusing about AMC clinical exam. And as I mentioned in the last meeting as well, it's more about my personal experience and the advice that I give to my juniors.
Mm-hmm.
That certainly doesn't mean that this is the only way or the right way of
Mm-hmm.
doing it. This is just my personal experience,
Sure.
which works. Right. So this is about the AMC clinical exam, and again, as we the AMC clinical exam itself, it's about there are about 20 stations. You've got 16 assess stations, and there will be 4 rest stations in which you'll just be taking a water break or something. And again, the question is how do you study? How much time do you need? How do you practice for it? And what resources? Before I talk about the resources, one thing that I want to highlight is that the biggest thing that I've seen in some of my juniors, and I think I want to highlight that is don't leave too much of a gap between your MCQ and your clinical exam,
Mm-hmm.
because at times it can be a daunting task that you haven't worked in an Australian medical system before, you haven't worked in an Australian environment, and all of a sudden you excuse me, you're faced with this challenge of going into a foreign country in front of English people who speak English as their first language, and you have
Yeah.
to examine these patients, and it is a daunting task.
Mm.
No one can say otherwise. However, after your AMC MCQ exam, your knowledge is really fresh. You've gone
Mm.
through most of the things, and you're already up to date with most of the guidelines, and that's an
Mm-hmm.
ideal time that you can just start working towards your communication skills, your structure, and
Mm-hmm.
overall organizing in the presentation so that you can have a concise and precise formulated presentation when you're actually presenting in front of an examiner. And I particularly feel that, again, depending upon your circumstances, you shouldn't delay it by more than 3 to 6 months. And 6 months should be a
Mm.
cap, because as you go past that 6 month mark, whatever knowledge that you had mastered and that you were it was a pinnacle of knowledge for you, that you mastered all your theoretical knowledge, it just starts seeping away from you, and
Mm.
ultimately you
Exactly.
just lose that touch. You want that basic knowledge, and you just want the clinical communication and structure to for the clinical exam to actually formulate and
You have to
help
build
you
on it,
in getting through
yes.
this. So I've seen some of my friends have been waiting for at least 12 to 18 months, because they keep on delaying that. And that's one thing that I really recommend. Don't do that, because it's
Mm.
just going to be difficult for you to do it once you've delayed it. Okay, as we have the handbook of MCQs for the MCQ exam, we've got our AMC handbook of clinical assessment, and this will formulate your basic
Yep.
basis. Again, like the MCQ, it's a brilliant book. It gives you a scenario, what type of examination, what would be the time that they will allocate for this
Mm-hmm.
task, and then it goes through what to expect. I always used to do it, that before you look at the answer, before you look at the explanation, time yourself, right? Whatever time you've
Mm.
got, 6 minutes or 8 minutes, whatever time you have, just time yourself. In those 8 minutes, whatever, just blabber. This is my question. For 8 minutes, just talk about anything about that question, right?
Mm.
Your brain will automatically start recalling a lot of that information that you've already gone through in your written exam.
Yep.
And after those 8 minutes, you just read that explanation. Half of the things that you would have said would be wrong. Half of the things would be correct. But then you'll be able to read the other half saying, hey, these are the things that I missed. These are the things that I should mention. And these are the
Mm-hmm.
things that I want to work on. And that forms an ideal strategy. And again, can't stress it enough. Once you've gone through a subject, for example, you've gone through medicine, you've gone through medical scenarios, you've gone through their explanations, you need to practice. It
Yep.
wouldn't it wouldn't sit in your brain, and you wouldn't be linguistically, you wouldn't be as articulate as we all of us want to be if you don't practice. And that is where role plays come in. A lot of the times when I was preparing for these exams, people said that you need a group, you need to discuss this with, you need to have a play group in which one person becomes the examiner, the other person becomes the candidate, and if you have a third person, that becomes a patient, or if you've got a dummy for a patient, that helps in actually developing your communication skills, your confidence, because you are talking in front of a different person and you're thinking at that time,
Yep.
and that automatically adds on to your confidence level when you're actually presenting in front of the examiner itself. Now, but again, as I said, this might not be for everyone. For example, for me, I never used to do role plays, and I used to take my time and go through go through things in a particular manner. And I always used to feel that I'm slowing down my growth, so I could never study in a group. And my way around it was that I always used to either do examination either on my wife or on a pillow, just because I wanted to get into that habit of doing examination on a daily basis. And similarly, it's not enough just to think about your answers, you have to say out your answers loud, right?
Yep.
Because that is how your communication skills will develop. Even if you're not confident initially to present it in front of a second person, you have a empty room. You either present it in a computer screen or just in an empty room in front of a pillow, imagining that there's an examiner and a patient in this room, and I'm presenting my case to this examiner, and be as formal, as articulate that you have to be, as just like you're sitting in an exam. And this is how you'll develop your communication skills, which forms the basics. Because at the end of the day, it's just an exam where they want to see whether you're safe and whether you know your clinical skills.
Yep.
Like we talked about the recalls in MCQ, similarly, someone formulated, there's this entity called Karen notes. Someone formulated these notes in which they divided all of these scenarios and clinical questions by subspecialties, and it can be really handy, where you have let's say 100 questions for medicine, you've got 60 questions, let's say 60 scenarios for surgery, pediatrics, mental health, behavioral questions, and you can go through that. However, it can be daunting, because if you have so many questions and so many scenarios to go through, you might not be able to go through everything. So if you can't go through the entire Karen notes or whatever notes you've got access to, don't worry about it. You just want to get an idea of the exams. You just want to have an idea of how the exam scenarios will play out. Similar, and some people say, oh, do 5 or 6 years of recalls, and it can become a daunting task. And ultimately, even if you do last 2 or 3 years of recalls, that will be a good start. If you've got more time, to do more. If you're not, then as opposed to doing more, just revise the ones that you've already done. I think it's a very lengthy exam in which you're obviously case after case. You're under a stressful situation where you've got these 16 cases. You read up. You've got a few minutes to read the scenario outside the room. You walk in a room, and then you've got a few minutes to take a history from the exam from the patient, and then you've got some time to ask for examination findings and investigation findings from the examiner, and then you have to come up with your differential and a management plan. And that takes a lot of stamina, and it can be really exhausting. But at least a few weeks prior to your exam itself, try to do at least 16 cases in a row, and that's it. Because that might ultimately be 4 or 5 hours of your time, but at least that builds up your stamina. That you have the tendency that you keep on talking for throughout 4 hours, and you can discuss, or 3 hours, whatever, that you can actually discuss these patients over and over again. And the division of time, it's just something that was suggested to me, but it's variable. For example, saying that 4 minutes for history, 1 minute examination, 1 minute for differential and management, I don't think that's enough. That really depends upon the STEM. If the STEM itself says that you take a focused history and then come up with discuss the examination findings with the examiner and come up with the differential, That means you can't be spending 4 minutes on a history,
It's
and
case to
that you have to
case.
go through. It's case to case. You have to take a very focused history to begin with, and then you have to ask for examination findings for the examiner. And it gives you enough time to talk about management strategies and management plans as well. So it really depends upon what kind of STEM that is. And this handbook will give you a good idea of what kind of questions would actually be coming up.
Mm-hmm.
Tele-O'Connor will form your basis of your examination, be it your AMC clinical or once you prepare for your physician exams as well.
Mm-hmm.
That formulates your basic examination strategies. And what I can't emphasize this enough that you have to do examination, at least one to do examination on a daily basis.
Mm-hmm.
Watching the videos of Tally O'Connor will give you a good idea regarding how do you examine, what step comes after
Mm-hmm.
what, but it should then formulate a reflex. Just like you do, just like with driving, you shouldn't be
Mm.
thinking while you're examining a patient, because when you're under exam situation and you're under a lot of stress, then at that time you can't be thinking, oh, what's the next step? You should automatically be doing the examination
Mm.
while your mind is thinking, what am I trying to find, and formulate a differential there and then. If
Yeah.
you're just struggling or what's the next step, then you've actually wasted an important part of important examination time.
Mm-hmm.
And that goes without saying that every night, either take a pillow or one of your friends or whoever, just do an examination, just do a split of examination. Try to do,
Mm.
for example, abdominal examination or cardiovascular examination, and automatically it will form a structure. And when you're talking about a clinical finding or trying to gather information, clinical examination findings from the examiner, you have to be very specific. What are you trying to ask? If you just say, "I want to know about the full blood count," that they might not give you an accurate, they might not give you full information. And it might not look good as well, as opposed to saying, I want to look at the full blood count that says what's the hemoglobin of this patient, as well as to see the MCV to see
Mm-hmm.
whether there's elevated microcytic anemia that will guide
Mm.
me in identifying whether there's any underlying iron deficiency anemia. As
Mm.
opposed to saying a full blood count, this leaves a good lasting impact on the examiner
Yeah.
who would know that you're specifically asking
You
for a
know what you're
clinical
talking
finding
about.
as well as an investigation, and that you have an idea of why you're asking for that. And
Mm-hmm.
be loud. Some of the examiners are really deaf, and it goes with that. I'm not kidding. You have to be really loud and very
Mm.
specific, that this is the examination finding, or this is what I'm looking for.
Yeah.
You have to make a show. This exam is, at the end of the day, it's about a show. They want to see whether you can examine. You have to, and I always say, you have to do the dance, right? You have to wash
Mm.
your hands. You have to show them that you're washing your hands. You have to dry them with a paper towel without spending too much time. And then you go on to this beautiful rhythmical manner in which you start examining a patient, and you just do the dance, and you get points for that. Um, and ultimately, the exam is to see whether you're a safe doctor. They
Mm-hmm.
don't expect you to be. They want to see whether you're at a level of an Australian graduate, right?
Mm-hmm.
And these graduates, they've got some clinical experience, but they're not proficient in their clinical practice. Which means
Mm-hmm.
that you have to be a safe doctor, and they want to see whether you can call for help when needed.
Yep.
When you're in an emergency setting, if you have a case of a non-STEMI, you've asked the nurse to take an ECG, you put the oxygen on, you've given some GTN to the patient. But now when
Mm-hmm.
you have an ECG in front of you and you're concerned about a non-STEMI, at that point in time, as opposed to say, or a STEMI, for example, as opposed to saying, I'm going to lyse this patient or I'm going to activate the cath lab, a sensible person would say, I'm going to ask for senior assistance so
Yep.
that we can activate the cath lab, or I'm going to ask for senior advice so that we can discuss about lysis or dual antiplatelet therapy for this patient.
Yep.
Similarly, when you're in a GP setting and if you've done the basic trust and it's a complex patient, you have to mention it as part of your management plan that I would take a specialist opinion and I would refer my patient for a specialist opinion.
Sure.
Similarly, if you're talking about a stroke patient, it's viable that you actually say that I will take my allied health team into consideration so that they can guide me in managing this patient from an allied health perspective.
Sure.
And that shows maturity, that you're not one person does it all. You're one person who's a team person who wants to take everyone,
Mhm.
and then take it from there. Some of these patients are actors, and they might flinch when you're touching them, and that's the show of pain. And if they
Mm.
are in pain, then you shouldn't be examining them in that area, and you should apologize for that as well. Just for the sake of completing all the steps, you shouldn't be going on touching a part of their abdomen, for example, which is tender. And that's another thing that you actually learn. As opposed to looking at the abdomen when you're examining, you have to look at their face
Mm.
while examining the abdomen to see whether they're in pain or not. And that's what the examiner is looking, that you are sensitive, you have that empathy for your patient as well, that you're concerned about their safety, their safety as well. This is some notes that were shared to me by one of my friends who was preparing for his USMLE CS exam at that time, and I found it really helpful. Not necessarily this note, but any note that you can gain access to. Have mnemonics for your history taking.
Mhm.
Again, when you're in a stress situation, and especially if you've got a difficult case, and at that time you're panicking, what's the diagnosis? What questions should I ask? This forms a basic backbone of your history taking skills. For example, OCD, PSF, AAA, I don't even know what that, I can't even remember what that stands for, but at least it gives you that idea that you have a question ready. So there's
It's
no
similar
awkward
to PLAB
silence.
in that sense.
Yeah, exactly. So I think any clinical exam for that matter, you need
Mm.
to have some mnemonics at the back of your mind so that you can actually ask those, you can actually have a question ready. And that buys you some time. For example, what are there any features which aggravate this particular symptom that you've mentioned? And the patient is talking for the next 10 seconds, and that's a vital time for you to think about your next question,
Mm.
formulate a strategy, and that is a vital time, those 10 or 15 seconds. So if you have questions prepped, some basic questions,
Mm.
obviously, depending upon the scenario, depending upon your the exam itself, you might have different questions. You might have to take it in a different route, but it gives you a structure. So definitely have those mnemonics ready.
What is the prep time you would recommend or advise? I know it's a clinical exam is different for everyone, but what is the prep time?
Yeah. Again, as I said, it's again 3 to 6 months. If exclusively you're not doing anything, you're not working, I would say don't delay it by more than 3 months. And
Mm.
especially after your AMC MCQ exam, your knowledge is still fresh. You've still got
You have
everything
to
in your
build on
mind.
it.
You just have to work on a pattern, a structure. And once
Mm.
you have that structure, you can implement that structure in every single scenario that comes through. And again, if you're working, if you've got other family responsibility, kids, then definitely 6 months is fine. But again, it depends upon your work, it depends upon your personal circumstances, and it depends upon how much time you have at your hand to actually study for these exams.
Sure.
But definitely don't delay it by more than a year, because after that it just becomes a hassle, and that's something that I really recommend.
To be continued. Like, share, and subscribe to learn more about what happens after the AMC exam and how to find for jobs, and especially the BPT, the medicine training pathway.